Good morning and welcome to the 11th meeting in 2014 of the Health and Sport Committee. As usual at this point, I'd ask everybody in the room to switch off mobile phones and Blackberries. We don't want them to interfere with our business this morning. Although I should also point out that officials and indeed some members are using tablet devices which are instead of their hard copies of the papers. The first item on the agenda today is the decision on whether to take item 3 in private. Item 3 is consideration of our work programme. Do I have the committee's agreement to take item 3 in private? Thank you. We now move to agenda item number 2, which is to return to our themed work on health inequalities. Today we have our second roundtable session on access to services. Of course, this morning we have a number of academics and professional bodies. A general welcome to you all. As it's a round table, I'll continue as I normally do and invite everyone to introduce themselves, and then we'll get to the first question. My name is Duncan McNeill. I'm the MSP for Greenock and Inverclyde and convener of the Health and Sport Committee.
I'm Graham Watt, Professor of General Practice at Glasgow University, and here representing the general practitioners at the deep end.
Bob Doris, MSP for Glasgow and Deputy Convener of the Health and Sport Committee.
Annette Milne, MSP for North East Scotland.
Hello, I'm Pauline Craig, Head of Equality at Health Scotland.
Aileen MacLeod, MSP for South Scotland.
Rhoda Grant, Highlands and Islands MSP.
Hi, I'm John Bird. I'm a GP at the Edinburgh Access Practice, which used to be Edinburgh Homeless Practice. I also work with the Drug and Alcohol Service in Lothian, and I coordinate a group called the Deprivation Interest Group in Lothian, which is a group of mostly GPs, but also other primary care workers and some social care workers working for high-quality, accessible primary care services for deprived and disadvantaged communities and groups.
I'm Colin Keir, MSP for Edinburgh Western.
Gil Patterson, MSP for Clydebank and Mulgai.
Lorna Kelly, Head of Policy at NHS Greater Glasgow and Clyde and representing the NHS Greater Glasgow and Clyde Primary Care Deprivation Group.
Richard Lyle, MSP Central Region.
Andrew BUIST, I'm a GP in Blair Gowrie and I'm the Deputy Chairman of SGPC of the BMA.
Richard Simpson, I'm MSP for Mid-Scotland and Fife and Chair, if I may just say, refer to my declaration, fellowship of 2 of the colleges, the medical colleges.
Okay, thanks for that. Richard Lyle, please, will you kick us off?
Thank you, Convener. Good morning, witnesses. Basically, the situation is that we have had various reports, and I refer to a report which you may or may not read. What can NHS Scotland do to prevent and reduce health inequalities done by deep end practitioners? They list various suggestions of additional time for consultation, support for serial encounters and productive use of long-term relationships, attached of staff from area-based services, etc., etc. And they go on to mention quite a number of things. I see in the BMA report, in particular to the BMA, but also to the other witnesses, that you have in your report suggested an integrated approach to health inequalities is essential for reducing those health differences. So I'd be very interested for Dr Andrew BUIST what his view is on the Deep End report.
Thank you. As I say, I am a GP in Blair Gowrie. It's not one of the deep end practices, but we do have pockets of deprivation within Rattray, so I'm familiar with some of the problems described in the deep end report. The solution to health inequalities lies with local services. As equally said, action starts with primary care, not in hospitals, and only tackling health inequalities through primary care with public health support can we reduce health inequalities. And by local services, I mean a one-stop shop built around the GP surgery with the GP, the social worker, the CPN, the drug and alcohol worker, the benefits advisor, all in one place. That tackles the transport issues that many people who are deprived have difficulty in. If I can refer you to an important document that this House commissioned in 2005, the CARE report. In the executive summary, Professor David Kerr said, "We need to view the NHS as a service delivered predominantly in local communities rather than hospitals. 90% of healthcare is delivered in primary care, but we still focus the bulk of our attention on the other 10%. Our current emphasis on hospitals does not provide the care that people are likely to need." That was in 2005. At that time, we spent 9.4% of the NHS budget on general practice. Since then, the percentage of the NHS spend has actually reduced to 7.8%. And that's why we are supporting the Royal College of General Practitioners, who are unfortunately not here today's national campaign to increase the percentage of NHS spend on general practice to 11% by 2017. We have insufficient focus on primary care. That's politicians, health boards, the media and subsequently the public, and we need to do something about it.
Want to pick up on that theme? Graham?
I think that's a very important issue, the extent to which the Scottish NHS is historically and still orientated towards hospitals and a hospital culture based around single diseases and specialties. An old paradigm. The universities, most of the research is based on the same paradigm, and that means that the huge number of patients who nowadays have several conditions who don't fit into the single specialties or diseases are not the focus of attention. The evidence base doesn't inform how best to look after those patients. So I think there is a big paradigm shift required in our focus away from the narrow focus of hospitals to the broader unconditional approach of primary care. The challenge is very much one of integrated care, because we're not short of resource, but we are short of joined-up resource. And there are three reasons why that's more difficult at the more deprived end of the social spectrum. One is the inverse care law. This committee spent a couple of hours, I think, recently with the Cabinet Secretary, in which neither he nor the members raised the inverse care law as an issue, which we found astonishing. It is an issue, a historical issue, which continues in good times and bad, so it's not an issue of austerity or prosperity. It's a question of whether the NHS, in addition to providing universal coverage and access, also provides the means for frontline practitioners to deal proportionately with the problems that patients present. Not a problem in hospital, but a big problem in primary care because of the flat distribution of manpower. That's just one of the problems, and the reason that our evidence focuses exclusively on it is because it so quickly disappears off the table. And if you do one thing, you must address the inverse care law. There are two other factors, though. One is, as Tudor Hart pointed out in his original paper, the ability of some social groups to access and use the service more effectively than others. I believe at your meeting last week you touched on this, the problems that people in deprived areas have in accessing a multiplicity of services for their problems, which are often not local, not familiar, not timely. I think creating those improved links at that end of the social spectrum is absolutely key. A service that is increasingly configuring itself to deal with a consumerist culture, encouraging people to self-help and self-manage, is the wrong approach for people with multiple problems in deprived areas. There's a third problem, and it also stems from the beginning of the NHS, and it's to do with the gap between the centre of the NHS and primary care, call it the independent contractor status. There are good things and bad things about it. It's been very good for pioneering approaches to practice. It's not been good for consistency between practices. But the system has had a problem in engaging with general practice. And if the system is to be built, to be rebuilt from the bottom up, it needs a more effective kind of engagement. The deep end is an interesting initiative because until 2009, the general practices dealing with the most deprived 10% of the population had never been convened or consulted by anybody, ever. So all the deep end representation is new. And we hope it's an example that can be built on. It's not something that can be transformed overnight, but there are certainly lots of places in the country where it would be possible to build on the intrinsic advantages of primary care, contact, continuity, coverage, relationships, trust, working with practices as hubs, linking through link workers and other resources to what's around them in order to provide continuity of personalised care for everybody, whatever problems they have. Okay.
Just before, because I would like a response to Andrew's, objective of raising the overall share to 11%. Does that won't necessarily deal with your inverse care law?
Well, there are two things, and they're related. The College and the BMA are absolutely right that primary care generally is under-resourced for the task that it's faced with. Absolutely no question about that. But within that, the flatness of the distribution of manpower is a problem, because at the deep end, you can't, once the day is done, you can't do any more. So unmet need, as we say in our paper, accrues and is not recorded. The problem with looking at manpower is it's 10 years since the government was able to collect data on whole-time equivalents, because since the new contract, the contracts with practices, not with individuals. So although we've made a bit of an issue of the whole-time equivalent manpower data, it's difficult to keep it up to date on a complete basis, even though the ISD survey last September confirms the picture that we recorded 10 years ago. If instead of manpower you look at practice funding, the amount of money that goes to general practices, which is used to pay GPs and receptionists and premises and everything, the average spend in the most recent year for which those data were available was £123 per patient per annum. So that's just over £10 a month per patient in Scotland. It goes on to the whole of general practice. And in the most deprived fifth of the population, that's 20%, so that's not a small marginal group, that's a big whack of the population with 1 million people in it. The average spend is £118 per annum. In the most affluent fifth of the population, another million, the average spend is 123. So, there's 5% more being spent on the most affluent fifth than the most deprived fifth. And you can't address health inequalities on that basis. In terms of the general point, clearly the origin of health inequalities are outside the health service. Everybody agrees with that. The role of the health service is to deal with the health inequalities that exist and to prevent them getting worse. We can narrow them by mitigating the severity and slowing the progression of the problems that people have so that they have emergencies and get admitted to hospital later or perhaps not at all. And the historical problem is that the health service has probably been producing inequality rather than narrowing it because of the inverse care law. But clearly this is just one of a number of policies that are required to address the fundamental problem. But our criticism of recent policy papers on health inequalities is that they have correctly focused on the early years, but they have incorrectly underemphasised the role of the NHS.
Okay. I'll let others try and respond. I've got two or three of the committee members want in. I'm just a bit worried about getting clarity, on a single yes or no, and I want to bring in some of the other witnesses, but I've got you here, Rhoda, and I'll let you in. Is any, I may be overdoing it, is any of the other witnesses wish to respond at this point? Yes, they do. So, Dr. Craig, and then John Budd and Lorna Kelly. I'll take them in that order. Yes, please.
Yes, thank you. In Health Scotland, our research really points to 3 roles for the NHS in health inequalities. The first is, as Graham says, is about mitigation and what we can do for people who are impacted on by social inequalities and how we do that better. And I would completely agree with Graham in having to think very differently about how we do that. I think areas of deprivation, for example, are not homogenous groups of people. So there's a lot of other things that we need to take into account as well as deprivation. And that's a problem around population databases. If we're focusing just on routine data and looking at deprivation, we're actually missing a lot of very small population groups, very marginal groups, and new migrant groups in particular coming into Scotland. So I think there's an issue about how we actually do that mitigation. And primary care and access to primary care is clearly the gateway to many other NHS services. But there's also the issue about what happens once people get into services, and are they referred on adequately? Do they continue to get the right kind of support that they might get in primary care? So the mitigation is really crucial for the NHS. But we've also got roles in prevention and undoing health inequalities, although these are maybe smaller roles. So prevention can partly be done through the NHS, but mostly be done in partnership with other public sector organisations. And the issue around that is about neighbourhood understanding, about really understanding communities and neighbourhoods and what the issues are. The issue about unmet need is impossible to get to through through just looking at population data from data gathered through service provision. We need to look much more beyond that to understanding the different groups in society. The NHS can also contribute a wee bit to undoing and reducing health inequalities because we've got very good epidemiological research. We've got a lot of research. We really do understand the links between social circumstances and health, and we could use that much better if we are able to work better in an integrated way at policy level as well as at neighbourhood level. So I think there's three different approaches that we can take: mitigation, prevention, undo. But we really need to get the mitigation right, particularly looking at equity rather than equality in health services. So it's not just about providing the same service for everybody, but really understanding what needs to happen around equity and being able to flex our universal services to deal with certain population groups or individuals differently. Okay.
John.
Hi, thanks. Yeah, I'd just like to echo something that Andrew was saying about the unique role of primary care in terms of trying to tackle health inequalities for individuals, families and communities. And I think one of the things that is unique about primary care is it has a very different relationship with patients and families than other health services. So I also work in the drug service, and we have limited contact. We're a community-based service. We'd like to think of ourselves as community-based. We have limited contact with families. We work with people for short periods of time. We seek to discharge people and get people moving through the service. Now, primary care doesn't do that. Primary care works with individuals and families over their life course. It works with individuals in their social context. It could be utilised in a much more effective way to address wider issues. It could be working to address prevention of inequalities through actually more involvement in community projects, more involvement with social issues. We have some welfare officers working in primary care. That could be expanded hugely. The integration agenda with health and social care could offer a really good opportunity to work more effectively between services. However, even at a meeting I was at up in Perth, organised by the Scottish Government, there were virtually no GPs there, and yet it was recognised that GPs would be key to the effective integration of health and social care. Yet GPs need to be enabled to participate, and increasingly GPs from deprived practices need to be able to be part of that debate and discussion about how that might work. So I think primary care, although it does offer the same medical interventions and the biomedical approach to addressing health issues, it also goes much wider and can start tapping into some of the social issues that are key to addressing inequalities.
LORNA Kelly, please.
Thanks. I wanted to build on some of the points about resources, and which were made in the context of general practice, but also to say that the issue of resources applies more widely to that broader primary care team and community services that were referred to, and that's both an issue of the absolute share of resource that primary care and community services have, and of then how that resource is distributed within services. And I think it's clear for boards at the moment that there are a number of drivers which push resource in the opposite direction, with many of the targets that will apply largely to hospital-based services, and lots of pressures pushing boards towards investing more and more within hospital services, and then the money that's available to use for primary care services, for community-based services is limited. There are then differences in the ability to apply that resource to need. So for community-based services, health boards have a degree of autonomy in how they share out that funding according to need, whether that be deprivation or other indicators. The resource allocation for general practice is done in a different way nationally. So there are differences in the ability to distribute the resource according to need. And also just to pick up on Pauline's point about it's relatively straightforward for us to understand SIMD and deprivation and think about how we might distribute resource according to that. But some of the other needs of smaller groups, groups with protected characteristics, much harder to see that from some of the routine data that we've got.
Thanks for that. I mean, out of all of that, I think there are a number of issues, although I've got Nanette and Rhoda. I want to ask a couple of questions, and Bob, but Nanette.
I mean, I found that really very interesting, actually quite salutary. So I think I quite agree that we need to be focusing much more on primary care. And with regard to integration of health and social care, I must say I went on quite a lot during the joint bodies, the Public Bodies Joint Working Bill, about the importance of involving GPs at locality level in planning, because I think that's where CHPs fell down, that their GPs weren't actively engaged with that, and I think that's hugely important. What I wanted to mention in connection with the report that Richard Lyle started the questioning with, having looked at the 10 measures that depend, 10 different measures, to address current and future inequalities in health. One group that doesn't appear to be mentioned anywhere, which I think are quite important, and that's the community pharmacy people. Because when I meet pharmacists in here, they actually see themselves very much as the gateway to health services, particularly in some of the more deprived parts of the country, where everyone sort of knows that. My mother in the old days used to take me to the chemist if there was something wrong before she would go to the doctor. And I get the feeling from the pharmacists that this would probably still happen today. I just wondered what the views around the table were on the importance of community pharmacy and all this.
Yep, that could be tie on the other question, because I think that's about the opportunities, if you believe it, so of the Joint Working Bill, or integration as we got into the habit of calling it, and the impact there. It might be useful to get a response about the opportunities there, or lack of them, or whatever. Graham, you wanted in, and then I'll go round.
I think there's a general issue that everybody thinks they're part of the solution and nobody thinks they're part of the problem. One of the problems is that there are too many hubs, people who see themselves at the centre of something. And I think there's on pharmacy, I think it's generally true that most general practices have very productive relationships with local pharmacies, and having made that step, wouldn't want to go back. The question is, what's the best relationship? The silver bullet in primary care is a continuing relationship of some sort, based on mutual knowledge, understanding, and there's a place for a variety of people doing that. It's not just one person. But I think that for people who've got multiple problems, particularly mental health problems and other problems in the family, that's a substantial task. And I find it difficult to see how that can be delivered in a mainstream kind of way through pharmacies, where there are other customers waiting in the queue to be served. So yes, but everything in its proper place.
room in 4 weeks' time to address the government's policy on prescription for excellence, which I support. The idea here is that we need to engage community pharmacy more with general practice, because I think they have huge amounts to offer in terms of patient care. I'm in a fortunate position in Tayside. We've had a practice pharmacist for many years, and he is hugely helpful in terms of things like drug reconciliation when someone is discharged from hospital, reducing drug interactions and mistakes that often cause harm to patients. Prescription for Excellence proposes to spread that across Scotland, and I think if it is achievable, it will be very good for patient care.
John? And then Dr. Craig.
Yeah, I actually, in my work with the addiction service, am based in a community pharmacy, actually, and it's been interesting to see the kind of relationships that pharmacists do have with patients, which is often a very informed, very caring relationship. And certainly, I have a colleague who is a prescribing pharmacist and who is looking at ways that pharmacists could become more involved in chronic disease management, particularly in terms of where people are on long-term treatments, prescription treatments and things. One of the difficulties, I think, is that particularly as the Deep End's work and Stuart Mercer's work has shown, and numerous other papers have shown, is the increased workload in deprived practices. And for GPs, for healthcare workers to work in a joined-up, integrated way takes time. And there has to be set-aside time to promote and maintain those working relationships. What I've seen in the 14, 15 years I've been working in Muir House in the northwest of Edinburgh is that that time has become less. And we see less of our colleagues in social work. We see less of our colleagues in mental health teams. We work in a less integrated way. And unless that is recognised and enabled, resourced, then integration is not going to work, because people keep their heads down, they do what they have to do, and they try and get through the day.
I mean, I think it is important to talk about the wider partnerships, although the question was, specific in terms of community pharmacists, but the wider importance of partnerships has been raised. Lorna Kelly?
Yeah, to echo some of what John has said, one of the primary care deprivation group within Greater Glasgow and Clyde, one of the most important things that has done, building on the Deep End work, has been to get people out of practice and into a room with other people working in the same sort of area. So it's enabled GPs and community staff from both health and social care to understand that each other exists and what their roles are and how they might connect into them. So a very simple example of a GP and a community psychologist sitting next to each other at a meeting and really didn't understand each other's roles at all or how to access those services. So I think we shouldn't underestimate the challenge of enabling people to understand the range of services that are around and how they can be accessed, and that challenge in an environment where general practitioners are spending the vast majority of their time seeing patient after patient after patient, and therefore not having the time to go out and meet people, understand what's going on in the services around them. And for not just for integration to work, but actually for the primary care team and the full range of community services to work effectively, and for primary care to have the sort of access and gatekeeping role that it can so valuably, you need to find good ways of enabling GPs to engage with that wider community within a context where they're under a huge amount of demand and pressure.
Rhoda, you wanted to come in?
Yes, just a couple of things. I was interested in what Graham Watt was saying about the amount of money spent on people in deprived areas and in the most affluent, given that Andrew Buist said there's a flat system of funding for GPs. I want to know how that then disparity happens in the handing out to that. I'm also interested to know about access to services. we heard last week about transport and issues concerning access to services. Should there be more practices, more hubs indeed, in deprived areas to allow people to access? I know I have difficulty accessing my GP. Can only imagine, you know, I live within walking distance of them. So, you know, if you have transport issues on top of kind of getting access, it must be much more difficult. So those are the kind of issues that I would be happy for.
Andrew, you want
address the finance distribution thing. I suspect that the reason for the £5 difference between the two areas might be due to the rural effect, and as a rural MSP you'll understand that it costs more to provide services in a rural area. If you are on an island in, say, Colonsay, 150 patients, you have one GP for 150 patients. You cannot get less than one GP. If you're in an urban area, you can have 1,600 patients per. So there's an economies of scale that will probably account for that small the £5 difference between the two. But it's important to understand that there's a sum of money called the global sum for the whole of Scotland. That's divided up by the Scottish allocation formula, which is a workload-based formula. It's not a needs-based formula. It's based on evidence on the amount of work involved in looking after patients. And the biggest determinant of that is age. And in fact, they had to do some damping down of the age factor because the number of consultations, the amount of time that a 90-year-old takes to be looked after is quite huge. And in some ways, practices in more deprived areas are paradoxically protected from that because the biggest indicator of health inequalities is that people are dying earlier.
Graham?
I think Andrew's right that the 5% difference is largely due to the additional costs of primary care in remote and rural areas. On average, I think about 20% more is spent per head on remoteness and rurality because of the easily perceived issues of remoteness and geography. In the deep end, the remoteness is of a different type. It's from good health, and that's more difficult to see. And on the issue of another explanation, I think, is that in affluent areas, the practices tend to be bigger. In deprived areas, they tend to be smaller. And I think that probably results in efficiencies in affluent areas from that point of view. There's absolutely no question that Andrew's correct about the workload associated with the frail and elderly who need house visits more because they can't come into the surgery. They take longer in consultations. That's a very important issue about which there's not a great deal of data. It's a separate issue from the one that we're talking about today because there are practices in which longevity is a fact, whereas if you're talking about health inequalities, longevity is an aspiration.
Dr. Craig.
Thank you. Just another factor that we are beginning to become aware of in Health Scotland. We've started to do some analysis around DNAs, the sort of do not attend, and people who don't turn up at services. We haven't completed these analyses yet. They're almost done. But the interim results show that they are very much socially patterned. So people who are in deprived areas are more likely not to turn up at services, or else the impact might be that they turn up late, and it's maybe more heavy use of services as a result of that. Now, these analyses are not done as a routine within health service analysis. They're done as research projects, and we're not really well set up to really look at data in the way to really understand some of that unmet need or exactly how people use services differently in different areas or from different groups. But we're starting to look at data linkage research, these DNA analysis to try and tell us a bit more about that. But it looks as if we're not really taking these issues into account when we're planning services at the beginning. That might also be linked to one of the issues that I was thinking about in relation to community pharmacists' question, is that if we're relying on people coming to services and articulating their problems, then we're actually again going to miss people who, where unmet needs are difficult, people don't speak English, or they can't manoeuvre their way around services and really find the gateway into the services. So we're maybe not doing enough of these kind of analysis to see who's not using services.
Yep. John Budd. And
right, maybe just like to pick up on a question that Rhoda asked about access in deprived areas and whether increased resources or hubs, I think you said, would help that. I mean, I think one of the things we've increasingly seen over the last 5, 6, 7 years is increased pressure on the whole primary care team, so that members of the team who would be much more operating on a much more outreach basis, such as district nurses, health visitors, community midwives, are now increasingly under pressure and less able to do that. There was a very good little study done in Craigmillar in the southeast of Edinburgh looking at midwife workload in 2 neighbouring areas. It's the same midwife team operating, and they audited their workload. And the workload to enable women who have multiple problems, social, mental health and drug problems, the workload associated with enabling them to access the service was a huge amount of the midwife's working day. And that's just to get them in, let alone then to try and deal with the increased number of issues, morbidities and problems that they suffer. So certainly enabling the primary care team to actually improve patient access through, it might be through new types of workers, it might be clinic support workers who have been used in Sure Start and different projects to facilitate engagement. Looking at new ways of facilitating that engagement, whether it's about, there was a very good project in Wester Hales which sadly lost funding, a patient attendance support project where receptionists were used to work on a much more outreach basis to enable patients to engage with primary and secondary care. There are things that could be done which wouldn't be hugely expensive but could make significant difference to patients accessing both primary and secondary care. And I think we have to look at that enabling and perhaps look at extending the reach of the primary care team if we are going to start to try and meet some of that unmet need.
Lorna, do you want in on this?
I'll maybe come in on the issue of DNAs that Pauline raised, if that's okay. And our analysis in Glasgow shows the same thing, that the DNA rate for the most deprived quintile is much higher than for the most affluent. And it's to make a point about the connection between hospital services and primary care and community-based services. So there are opportunities with DNAs, and particularly for children and vulnerable families, to vastly improve the relationship between secondary care and primary care, so there's much better knowledge about when patients are not turning up, and that the most vulnerable families are being identified, because not turning up to an appointment may be a symptom of much wider problems within the family. The second point about hospital-based services is that there are some of our services where there is a disproportionate use or access, you might call it, from deprived areas, and that's particularly A&E, where within Glasgow and Clyde, nearly 50% of our A&E attendances are from the most deprived populations, against about 34% if you were to look at the spread across the population. So people are accessing services, but accessing them in a different way, and there's a real challenge for us then to respond appropriately to that, because A&Es are set up to treat a presenting issue and send people away again. But if you have multiple presentations, usually with underlying chronic disease or underlying mental health or addictions issues, there needs to be a better way to connect from A&E back into primary care community services, where you can develop that ongoing relationship and have some chance of dealing with the underlying issues. So that relationship across the system, I think, is critical.
And do you want to come back?
Yes, on that particular point, if primary care is under-resourced, lack of time, then the work will spill over into other sectors like A&E as night follows day. On the question of DNAs, It's a pity my colleague Petra Sambali from Postle Park isn't here, because she would speak passionately about her patients being asked to travel longer distances to hospitals because of centralisation, DNAing, and then snakes and ladders to the bottom of the queue, out of the system. So it becomes difficult. And that's why one of the deep end main arguments is that the distances between the hub and the rest of the wheel need to be short. The referral distances need to be short. And one of the ways of doing that is to bring services closer to the hub through attached workers. It's not a solution for every practice because they wouldn't have the volume of caseload to justify it. But in mental health, for example, there's surely a sufficient burden of need to justify, at least as an experiment, the attachment of mental health workers so that the referral distances are that much shorter. The point I wanted to make was to do with homelessness and other marginal groups. They do have access problems in the way that the most deprived million don't. Their problem is not access, it's what happens when they use their access. There's a lot to learn from the homelessness service. I learnt that at a conference recently in London, reviewing homeless services in England. And of course, there's a growth industry of homelessness in England and of services to respond to it. And the services are very good, as indeed are our homeless services in Edinburgh and Glasgow. In particular, they have developed a very personalised approach to the particular needs of patients in that group with their problems of attaching and engaging with services. And they're also very good at providing an integrated approach, because the other services are configured round about the homeless services. In a sense, it's a model for the rest of primary care, that we're dealing with patients who are difficult to engage with. You know, at this conference it was said that hard to reach should be deleted from the lexicon and replaced by easy to ignore, because they are easy to ignore. And the homelessness services, I think, have developed very useful ways of developing services around patients who are easy to ignore and difficult to engage with. And I think we need more of that model in the mainstream than we do at present.
Thanks. Bob Doris.
Thanks, Convener. I wanted just to come back to a couple of the statistics that were given, I think, by Dr. BUIST and Graham Watt. So, Graham, you were saying about the £5 gap between the poorest 20% and the wealthiest 20% spend, and Dr. BUIST was talking about the fall in the amount of monies from the health service budget being spent in GP's practice from 9.4 to 7.8%, but then with the aspiration of that going to 11% by 2017. I know they're very important numbers, but they are just numbers, and I'd be interested to look at what the trend is going forward. So, for example, there may be reasons to explain that £5 gap, but in 5 years' time, has that narrowed, has that changed, has that altered, has there been a shift, and likewise in relation to the percentage for GP's practices. But I'm quite keen to get what the outcomes would be and where those monies would come from if that was going to happen. And I think John Budd was starting to talk about some of the new initiatives, as was Graham Watt, that might happen. So, for example, acute care has been mentioned, and I need to specifically mention health and social care integration, because one of the big ideas around that is picking away some of that acute care budget and putting it back into the community. And local authorities were very keen on that. Local authorities were less keen at picking away at their budget and putting that into new community initiatives. So I would quite like to get on the record from some of our witnesses here today where they see that shift coming from whether it's local authorities or acute budgets into the communities, and whether it's the GP's hub has to be GPs directly in control of those budgets, or whether it's about co-location and integration rather than GPs always leading on that. So it's just to try and get on record how we, all these worthy aspirations we have, and I completely share and everything, all these aspirations, but how we actually take it forward and how we monitor it.
Yes, please.
I mean, it's important to understand that the reason that the percentage has fallen is not because there's less money going into primary care, it's because the new money that's come into the system has disproportionately been diverted to hospital care. The variation between the most deprived and the least deprived, you could adjust that. you could adjust that because you could change the formula that divides up the money, but you would effectively move money from rural elderly practice service areas to deprived. And my belief is that we need to shift more money from other parts of the system into primary care to provide the services more locally, to keep people in their community so they don't need to get 2 buses to go to a hospital. I think the key to doing that in a positive moment is health and social care integration. If we can crack that, then that is the way to do it. And it is essential that we get general practitioners involved in that from all types of practices, deprived practices, less deprived practices. We need to get general practitioners, working general practitioners involved to look at the services and how they're provided, look at the patient pathways, get the social care and the health care working more closely together. So the secondary care legislation that you're looking at just now needs to write that in to enable that. But we also need to make it possible for GPs to get away from their practices for an afternoon a month to get involved in that. And that is, the early signs are that's going to be difficult because we are seeing early signs of a workforce crisis starting to appear in general practice, and it's happening for several reasons. General practice has lost popularity with the young doctors coming into the profession. Older doctors are leaving slightly earlier in their late 50s rather than hanging on into their early 60s. And we're also losing doctors in the middle of their careers. Last week, women outnumbered men in terms of general practice workforce across the UK for the first time. And women, when they, and I think that's a good thing, and when they go away to have their families, they're not coming back into the profession. And one of the reasons for that is they're frankly burnt out. The workload is becoming intolerable. We are battle weary, and it's not something that's just particular to practices providing care in more deprived areas. It's across virtually the whole spectrum of general practice. I've been a general practitioner for 20 years. Yesterday I saw 40 patients face to face. It was an 11-hour day. There was almost no time. Lunch was 5 minutes. And that's a marked contrast with 11 years ago. In those days, I might have had 2 hours to myself in the middle of the day. The day starts earlier, it finishes later, and the bit in the middle is gone. And general practitioners are absolutely weary. They're increasingly working part-time to try and cope with the demands. And we need to do something quite quickly to stabilise the workforce. Otherwise, we won't have we'll start to see the situation you'll be aware of in Cumbria, where they're having difficulty providing a practice, and they're running it with locums, and it's costing about double the cost of the routine service. You're going to start seeing that in other areas. It's going to particularly hit rural areas first, deprived areas, and the out-of-hours services. And it will also make locums increasingly difficult to find. And that's important because it's the locums that will provide the backfill that will allow the GPs to get away from their practice to get involved in health and social care integration.
Other comments, Graham?
Just to comment that the Deep End project would never have happened if there hadn't been the possibility of backfill. Otherwise, the practitioners, we say, what have Deep End GPs got in common with Dracula? They only come out at night because during the day they're seeing patients. So that it might seem expensive, but actually I think it's not expensive. It's a small investment in order to get people out of practice, to reflect and to meet with colleagues. On the general question, the data I gave earlier, which this committee could get from ISD if it asked the question, one of the things is that very few official analyses are based on groups of practices serving different parts of the population. They tend to be based on geography, which is around NHS management, rather than the distribution of need within the population. But the figure of £120 a year is £10 a month per patient in a deprived practice. That doesn't seem a lot. A small increase in that doesn't seem to me a lot, but it would make a huge difference within practices. But, the bottom line here is that if the health service is not at its best where it's needed most, it will widen inequality, which is what this committee is trying to address. So ultimately that's, I think, a political question. If it's left to the service to work out who should get what, then you have not an evidence-based policy, you have a noise-based policy where the people who make the most noise get the most resource. That's our historical experience. So I think there's a need for informed decisions to put values and principles into effect. And if times are difficult because of austerity, well, surely we're not saying that equality and equity is something we can only afford in good times. I mean, that sounds like a rather English debate, not a Scottish debate to me.
Just to build on a couple of the points there, there is an opportunity through health and social integration to really think differently about inequalities. Rather than basing our planning on routine data and for the whole population, we can bring maybe some data, some research to that process from what we know about rurality, about the homeless services, about the services that have been responding to migrant groups. All of these, the knowns around these need to be built into the health and social integration planning so that we think about inequalities at the very beginning and we don't rely on an equality impact assessment to be done at the very end of a process that just protects us from legal recourse, but actually brings some of that thinking about inequality up front and we really think about the people who don't come to the services first, and then we think about the whole population instead of thinking about the whole population and then worrying about the people that that don't come. I'm slightly worried that we go down the route of projects and initiatives in order to sort of bridge that gap. I mean, the experience we've had so far is that projects and initiatives can do a huge amount to bring people into services, but if it's not part of the mainstream services, the projects and the individuals involved in these initiatives disappear over time, and we're left with a whole population approach within the mainstream services that's continuing not to meet the need of the people who are not able to come forward. So there's something for me about building that kind of thinking into the planning at the very beginning, and with the new process in place of health and social integration, that gives us an opportunity to think quite differently about inequalities at this point.
Yeah, I'd just like to agree with Pauline there about the importance of utilising the infrastructure we already have and building on that, and that's the infrastructure of primary care. In terms of what Bob Doris was asking about integration and funding with regard to local authorities, I work in the Edinburgh Access practice, which is part of the Access Point, which is co-located services, that's social work, housing, and working very closely with third sector colleagues in homelessness. We do provide a very joined up and partnership-based approach, which is really vital working with patients with multiple and complex needs. A key part of how we work is our relationship with the third sector, who, in terms of working on the street, identifying and engaging with vulnerable and isolated individuals, their work has been absolutely key. Often they will work with folks, perhaps drug users, who aren't involved in services over a period of time, establishing relationships, and they'll bring them into the mainstream services. And that can take quite a while, that process of fostering engagement. What we have seen over the last few years with tendering, commissioning from local authorities is that those services have disappeared. There virtually is no outreach street work for homeless people in Edinburgh, as far as I can see. One of the issues with that is tendering and commissioning on an outcomes basis, because when you have an organisation that has tick box outcomes to fulfil, what you don't want in your service is patients who aren't going to tick the boxes. And the people who aren't going to tick the boxes are going to be the most vulnerable, the most chaotic, the ones with the biggest problems. So what you end up with, perversely, is services for vulnerable and marginalised people that excludes them, because they're not going to tick the outcome boxes and you're not going to get your funding. So we've seen, increasingly now, I think we're seeing patients who are most at risk are least able to access our service. So I think that's an issue in terms of local authorities, about how services are funded and how they're monitored. I think that's one of the great advantages of primary care, is that we don't tick boxes and exclude people. We don't have referral criteria. We will take anybody, and we will work with them as long as they're willing to work with us and come. There's no other service in health that offers that. What we need, perhaps, is what we do need definitely is more help in terms of the increased workload, particularly in deprived areas. And we need to think about how we can enable people to engage effectively with us and then utilize what we have to offer. And when you're working with patients with multiple and complex needs, it's not just a matter of them turning up and everything being okay. It's a matter of long-term, slow, ongoing relationships and work. You know, with Richard knows through his work in addictions, these small steps can take years and years, and you see very little outcomes, but it's a developmental approach because you're dealing with people who've had significant developmental issues from birth and sometimes from before birth.
Gert.
My head, I have to say, is bubbling with different things, but I want to concentrate on just a couple of issues. Having been in general practice, 30 years ago we had attached social work, we had an attached CPN, and we had an attached school nurse. They were all withdrawn from the practice. The school nurse retreated into the school. She used to come once a month, but it meant that we were able to discuss issues like asthma management in school, epilepsy management in school, and share information. On the social work side, the social work was attached to 3 practices, 2 of which were the most deprived in our area, and the child registration for protection dropped, but the child referrals from within the practice to the social worker went up. So there was a very positive outcome to that. Now that's all 30 years ago, and the pattern, it seems to me, since then has been the gradual withdrawal of services, so that even in deprived areas, health visitors are no longer co-located with the practice. And that to me is utterly shocking, because the development of a network of individuals who support an individual and family with need requires that degree of integration. And we can sit here for as long as we like and talk about health and social care integration structures at the top and the bills that we've passed to do that. But unless you get it at the coal face, it seems to me that it won't work. So my question, Chair, finally come to it on this bit, is we've had the 17C contract as an alternative to the standard independent contractor GMS contract. That has been in place now for something like 12 years, and yet it is not being used to actually create a service in many areas. And I wonder whether, as part of the move towards a new contract with general practice, which is being now talked about openly, and I welcome, that we really need to think about a much more fundamental shift from the 1948 model of general practice. And I just wonder what those witnesses present think about the potential for creating a completely new contract. One final point. Under the Labour coalition, and I think under the SNP as well, there have been a number of multidisciplinary centres created. There was one in West Lothian, and there was one, I think there are 2 in West Lothian, there's one in Ayrshire that have been referred to repeatedly, where there has been co-location of mental health teams, of social work, of housing, of benefits officers, as well as general practice. And I just wonder if these have been evaluated. They are expensive. I mean, the physical building is expensive, but the co-location of these teams seems to me to be the ideal, but is there any evidence that that is the case?
I think Andrew wants to come in on that.
Yeah. I mean, we are, the BMA, in discussion with the Scottish Government just now about revising the GP contract. But, I mean, I don't think it's the whole solution. I mean, in passing, one of the things that came in 2004 was the Quality and Outcomes Framework. And now that was a good thing. And I'm sure Graham will say that was something that improved standards across all practices. Things like diabetic care became more standardised, less variation, and so it helped reduce health inequalities. So it was a good thing. But over the years, over the last 10 years, it went too far. It became too much tick boxing. Unfortunately, last year we started a reversal of that trend to make it a more professionalised contract. And we're going to continue working with the Scottish Government to do that, to make a more professional-based contract so that we get these more hard-to-reach patients rather than avoiding them because they don't fit the boxes. You know, the model of general practice, I think, is a sound one. The Commonwealth Fund last year said that the UK general practice was at the top or near the top for every parameter that they looked at. The problem that we faced, as the King's Fund said, was a chronic lack of capacity in general practice. And the only way we can address that is to increase the share of the NHS budget that goes into general practice. Which contract underlies that doesn't matter so much. My own view is that a national contract is better because you know, it reduces the variation between areas. And additional funding, well, you can give additional funding through 17C or you can give it through the GMS contract. It doesn't matter. But I think that the underlying problem is inadequate funding going into general practice. As Graham said, you know, £120 for a whole year's general practice care, when the cost of one A&E attendance is £100, one outpatient attendance £112, and yet you get a whole year's care with your general practitioner, on average 6 face-to-face contacts per year, and that's something that has risen from 4 face-to-face contacts 10 years ago, and is one of the reasons why we are so battle-weary, is because we're seeing more and more consultations for the same resource.
Richard got a point about, and it's been mentioned earlier, about the hub, that it shouldn't just be about the GP, that can give you that increased capacity, the alternatives are advice in housing benefit, you know, that you know, when people are coming to see me, they're extremely upset, they're ill with the worry of this. So it's not necessarily a GP, but that co-location of social work or housing help or mental health. Sam H is up the hill, or, you know that.
Absolutely. I mean, I addressed that in my opening remark. That I mean, the GP practice is the natural hub to build the extended primary healthcare team around, with the CPNs and the social workers. And not only does it make it more convenient for the patient, it also means the lines of communication between these different workers is shorter. We meet them over the kettle, and we continue working and exchanging information about patients. If we're working in different buildings, these exchanges don't take place.
As I said before, the service has too many hubs, services which see themselves as centres, which deal with their own problems of resource by waiting times and rationing access, making it difficult for patients with multiple morbidity. Now, Spike Milligan describes a machine that did the work of 2 men and took 3 men to work it. Well, that's the health service in a nutshell. We can't afford it. We need to imagine a machine that does the work of 2 men and takes 1 person to work it. Well, I think that's general practice, not because of GPs, it's because of the intrinsic features of general practice, which is it has contact, coverage and continuity. The continuity, the coverage deals with the equity issue. The continuity means that there are multiple opportunities to start. Everything doesn't have to be done today like it has to with initiatives. So that needs to be built around. The question of, I think the most difficult issue is the sharing of power, resource and responsibility. That's the most difficult issue because of how the system has developed. And the adoption of power, responsibility and at the practice end is a tender plant. It's not going to be transformed overnight. It's something that we need to develop and grow. There's a proposal to government at present based on the Govan Health Centre, where there are 4 deep-end general practices, where in partnership with the Director of the local CHIP and social work, there's a plan for a bit of additional capacity to address the inverse care law, attached social workers, not inventing that, but going back to it, link workers to the community resources for health, plus protected time to allow the practices to work together and with others within the locality planning process. So there's lots of things there that have the potential to grow. It's as much a cultural development as it is a managerial development, and that will take time. So it can't be given too heavy a burden of expectation, because the problems that we're addressing are not going to be transformed overnight. On the question of the contract, you know, there's a quote written on the outside of this Parliament building from a man called Andrew Miller, who says that if you could only write the ballads of a nation, you needn't pay any attention to the laws. And I understand that is the contract is the laws. The ballads is the songs that people are singing, the cultural and shared values within the system. That's much more important than the contract within which people work. That's to do with the quality of relationships, not just between practitioners and patients, mutuality and trust, but between practitioners, between leaders at ground and top level. You know, the quality of relationship sometimes between the top and the bottom is much worse than it is between practitioners and patients. And we need to have the same ideas of co-production based on mutuality and trust at all levels of the service. Co-op was expensive. Its most important achievement was to introduce consistency of information recording and organisational arrangements within all practices, because it had 100% engagement virtually. Very few things have 100% engagement. It accounted for about a fifth of earnings. There's a slight gradient towards deprivation, but the difference is £2 across the range. In hand services, the gradient goes the other way. The rest of the global sum is flat. So QOF has not been a particularly progressive measure. The problem with QOF is that, as we know from PTI data, only 12% of consultations in general practice involve a QOF condition. You know, what's happening in the rest of them, and how are they valued and incentivised? That's what Andrew's talking. We need to get back to rewarding GPs for working with the more complex kind of patient.
We've, you know, I think there's a lot of agreement around the table. We've got an issue, but Richard, I mean, we've got half an hour left, and I'm anxious to get to a stage. Maybe you can help me your question, that we actually address the contradictions in policy, the contradictions in share, how the resources are allocated, and what we should be doing about it. And, you know, if there's anything, we obviously will have a discussion with ministers about the evidence that we've had, you know, so there's some challenges in there. Richard.
One of the issues we discussed in the very first Parliament was the Arbuthnot formula, now known as NRAC. And one of the exclusions from the technical side of that has been general practice. But the data wasn't there. It just, you know, wasn't there. And as far as I understand, it's still not there. So, you know, the ability to distribute or to require health boards to use the formula to distribute is just not there. And I think that that's a really sad lack, and I hope we'll get NRAC in front of us to explain, because they were supposed to do the work to get this sorted out, and I don't think that it's been done. But the other bit of that is, of course, that the money that's gone to health boards on the basis of the general distribution for deprivation has been used for all sorts of pilots. In fact, even, you know, the initial formulas going back to 1976 were used for things like the Paisley Have a Heart, or is it Midspan, or, you know, there have been these projects. They've all been add-ons. Instead of using general practice as the hub, where there is the continuity, the only place that people are actually registered for, often for life with a general practitioner, they've been actually going out and just doing it with these groups. And I'm convinced the Keep Well programme will demonstrate the same thing. These programmes have not achieved any real improvement in outcomes at all. Now, that's where a lot of money is being spent on these programmes that have not proved to be effective. And the other one is health checks. You know, to do health checks of people between 45 and 65, there is no evidence for that, and yet we're spending a lot of money on it. So, you know, in terms of redistribution, do the witnesses feel that there are areas like that, and these may not be the appropriate ones, but are there areas where we can take money that is currently being spent and use it more effectively? And should we be requiring NRAC to give us a much better distribution formula for deprivation in primary care as opposed to secondary care where it's actually applied at the moment?
Any takers? Andrew, then I'll...
Well, the Minister, Alex Neil, came to our conference 2 weeks ago and told us something which we welcomed, that the territorial boards in their local delivery plans would be required to evidence significant increase from April onwards in their spend in primary care with their above inflationary uplifts. Investment in primary care was essential, and he said he could not deliver the integration agenda or the 2020 vision without it. Where would we spend it? I think we need to get the average list size down. The average whole-time equivalent GP in mainland Scotland has around 1,500 patients. I think that is too much, too many people for the type of care. It might have been okay 40 years ago for the type of care that was provided then, but it's far too many patients now. I think we need to expand the primary health care team, more district nurses, more health visitors, more counsellors. We need to invest in infrastructure. There's almost been no investment in new premises across Scotland in the last 10 years, and the population of Scotland has, in that time, has increased by about 250,000 people, and it's unevenly distributed, with Lothian, South Fife and Forth Valley having higher rises than elsewhere, and that is impacting on the current services. Many practices in these sort of areas, Lothian in particular, are closing their lists because they're bursting at the seams. They cannot provide the care that people need in the space that they have and with the workforce that they have. So we need to invest in new premises, and it was mentioned earlier, we need to build new premises and perhaps bigger premises in areas, deprived areas. Bring these single-handed practitioners together into a hub with the other services attached. And we need to invest in out-of-hours care, which is a bit of a Cinderella service, but actually provides a good standard of care, certainly compared to the patchwork arrangements down in England, but they are under-resourced compared, I think, to some of the secondary care services, and they are vulnerable because the workforce is moving away because the support is not there.
On the question of NRAC and the Arbuthnot report, we had the best intentions, we had the best methods and statisticians, and to some extent we had the best data. Although, as Pauline points out, the data you've got isn't necessarily the data that you want. But using activity as a proxy for need systematically takes no account of unmet need. In the deep end, practices are unable to generate activity that reflects need, so it goes unrecorded. NRAC specially commissioned health economists in New York to see if they could find unmet need, and they couldn't because they were sitting at a desk in New York. If they were sitting at a desk in Govan or in Postle Park or in Easterhouse, they wouldn't have a problem finding unmet need. The trouble is that if you use other measures of need, like mortality, it frightens the horses. It frightens the horses because the arithmetic implies very substantial changes that would be politically undeliverable. So I think that the argument has to be one of progressive change over a period of time, not overnight. The points that Andrew makes about recruitment are really important. They're going to impact across the service, so it's not particularly a deep end issue, although it's particularly important in the deep end. I think we have an advantage in Scotland in that the most severe areas of deprivation are concentrated around Glasgow, where lots of people want to work. So we don't have problems of under-doctoring that you would have in South Wales or in parts of London and Birmingham. We've actually got a high-quality workforce in deprived areas in Scotland, and are better placed internationally than probably anywhere to show what a needs-based service could actually deliver. I think that's one of the challenges for Scotland to address. But what we need in the deep end are models of professional careers and opportunities which inspire the next generation. And that won't require financial reward so much as professional reward. I think the leadership role in deprived areas needs to be recognised and supported in addition to the clinical role, so that in 10-20 years' time we have a cohort of people who at ground level are leading the development of hub-based local health systems in partnership with other leaders in healthcare. We don't have that at present, but we have the potential to build on the deep end, and not just the deep end, because everything that's argued for the deep end needs to be applied pro rata across the system. If you simply solve the deep end problems, you wouldn't have addressed Scotland's inequalities, because they're patterned across the population. So the policy has to be a pro rata one across the board, but the deep end is a place to start. And I would like to see much more support for leadership roles in that area of the health service, because the leadership role can't be imagined from far away. It can only be developed locally based on local knowledge of premises, of populations, of colleagues. That needs to be enhanced. And the type of leadership that's required is not the same kind of leadership that you require of a clinical director on a chip or a secondment to the Scottish office, working in a big bureaucracy. It's leadership in the local microeconomy of a general practice with its local community. At the moment, leadership in those contexts tends to be exceptional and notable because of its novelty, and we need to make it more mainstream.
Well, yeah, can some maybe address some of this as well, because we started off by saying rightly that this is not just an issue for health. We can mitigate, and I presume everybody agrees that health should be taking the lead in this, given that it's the only one that's got clearly health inequalities as a priority in its portfolio, and some of the other portfolios haven't. But in terms of shifting a greater share from hospitals to GPs, increasing the number of GPs and whatever, is that not repeating the same? Is that not contradictory to the basic argument that this isn't just an issue for health? If we're going to give more money there, at the same time as reducing money in local authorities, the impact on social workers, reducing, if there's going to be a shift of money, is it just the GP practices? Is it just about recruiting nurses, or is it, the people who deal with a lot of elderly people on a day-to-day basis, who've got more contact with them on a day-to-day basis, are home helps and care workers, who spend, maybe at too short a time, but they're there every day. So where should this investment go? If we're serious about it's not simply health, where should this bigger share of the money go when we're cutting housing budgets because of pressures, and we're cutting local authority budgets because, it's a bit contradictory for me at this point. But John and Paul.
I think you're right in terms of the frail elderly with home helps and care workers, but the vast majority of my patients don't have any care workers. They don't have any home helps. Working in a deprived area, the thing that marks out those who have chronic illness is that they're younger adults. And through Graham and Stuart Mercer's work, we know that patients have multiple long-term morbidities 10 to 15 years earlier in deprived communities. Most of these don't have care workers. They don't have home helps. The people that they come into contact with, are GPs and people around the practices. It might be district nurses. And yet the people who are most under pressure in terms of providing those general services to communities are those same people. So I think unless we actually resource the primary care team, it's not just GPs, but unless we resource the primary care team, then in terms of improving access for vulnerable patients with multiple morbidity, we're not going to be able to do that.
Lorna and then Dr. Craig.
I wanted to pick up on some of the points about how information and policy drives the way that resources are allocated. And I made a point earlier around a number of drivers that cause boards to invest more in acute hospital care. And that's partly because the nature of those drivers is they're easier to count and easier to put money into. So A&E waiting times, 18-week referral to treatment, the drive for us to have more senior decision makers working 7 days, all of those things are easy to quantify, easy to say, if you want to see everybody in such and such a time, this is the additional number of doctors or nurses that you need. And all of that drives more and more money into secondary care. And we don't really have an equivalent for primary care because we can't see patients who can't get appointments. We can't see the increasing demand. We can't count it in a way that says, actually, how many GPs do we need? What are the services and the numbers that we need across, whether it's GPs or other health and social care services. So there isn't the same hard edge that drives some of that resource allocation, both within boards and at a national level in terms of the debate that we can have. The other issue I wanted to pick up on, and your point about whether we should put money into healthcare or social care, one of the other things that is driving spend or within the acute setting is still the problem of delayed discharges and the concerns around social care funding, meaning that people are staying in one of the most expensive parts of the system in an acute hospital with all of the knock-on consequences that has. So that overall balance of funding between across health and social care is really important, because a problem in one part of the system, as Graham pointed out earlier, simply pops up in another part of the system. And those areas which can't close their doors and wouldn't want to close their doors, like general practice, like A&E, are the last resort for a number of people, and then there's a risk that people get stuck in a place that's not appropriate and is not the best use of resource.
The issue for me is not so much about who do we put the money or where do we put the money to, but what is the outcome we're actually trying to achieve. And if we're trying to achieve earlier and more responsive services, earlier and better response to the needs of people who are less likely to be able to articulate their need, then that's the place that we need to put our money. We need to really understand the need, and we need to have a service that actually wants to do that. And at the moment, policies are not clear about, we talk about health inequalities, but in very vague terms, but they're not clear about what that actually means for the NHS and who we actually want to target our resources at. So if they continue to be based on population data and based on an expectation that people will come forward to services, then we're not actually going to get to meeting the need, and we'll continue to have more and more people going to A&E, and so the issue is about how do we actually reach people. So one of the things that came out from the initiatives that Richard Simpson talked about, they didn't maybe achieve the health outcomes expected, but what they did achieve was evidence that tells us how much effort had to go into improving access to to people to services, very specific services, and some of the other initiatives, homelessness services for gypsy travellers, etc. It's a huge amount of effort put into that, but most of that isn't funded, and it's not funded as part of the mainstream. It's project funded. So if we have a different outcome for our services that is about providing services to people, in these situations, then that will maybe help us decide who it is that we need to employ to be able to meet these needs.
Yes, Lorna, then Graham.
To follow up on that point, Keep Well is a good example where, because health outcomes haven't been obvious from the work, that funding is gradually being withdrawn, and that the funding like that are used creatively by health boards to do things that meet the needs of the local population. And it is a resource that's used within primary care, and that, as just an example, is a resource that then is gone, and you don't necessarily see where it goes, or to say, well, if it didn't work, why not? And is the is the message that we should put more into mainstream primary care, the projects stop and disappear off into something else. So I think there is a discipline around some of the national projects and initiatives to say, well, if things didn't work, why didn't they work? Did they not work because they were an add-on project? And where do we take the learning from those to mainstream them into practice? And by mainstream, I don't just mean continuing the funding for that particular project. I mean looking at the core resources that we've got around particularly our universal services and how those need to be shored up or could achieve the same or better outcomes as some of the separate project-based approaches.
And Keepwell was very good at processing, eventually, a very large proportion of the population in terms of assessing their cardiovascular and other risks. And the infrastructure that was good for that isn't good for what's needed next, which is the continuity of care that these people need, not just for their cardiovascular risks, but for everything else. So that's the disjunction, and that's why I'm not sorry to see Keepwell come to an end, because I think it reached the end of its useful life and the resources need to be used in a different way. I want to come back to the issue you made, Chairman, which I think is very important. You know, after all of this discussion, are we just talking about giving more money to GPs? Clearly not. If it's framed in that way, it's a very unattractive option. The way GPs are paid through the contract is that the funds that are available are both for income and for service development, and clearly there's a conflict of interest there. To increase the channel of funds through that route is unpopular with other practices who see deep-end GPs potentially earning more, although in fact I think in general they earn less. I think the aspiration is simply to earn the same as everybody else, and after that professional rewards are sufficient, not financial rewards. The model of simply giving money to GPs is unattractive to the NHS because it sees GPs as being unaccountable for the public health need and for service development. So framing it in that way is a very unhelpful way, which is a guarantee of nothing happening. What's needed is something rather different. There does need to be an injection of additional clinical capacity within deep-end practices, not to equalise the inverse care law, because that would frighten the horses and is unnecessary. It just needs, as I've heard the Cabinet Secretary say, something to ease the pressure of GPs and to allow other things to take place. The other ingredients are attached workers, social work, health visiting, protected time for the development of a leadership role in partnership with other leadership roles within local health systems. I think what we need are models of developing local health systems around practice hubs, which involve all of the players that we've mentioned this morning. GPs, sometimes I've heard people say to this committee that if only GPs were salaried, that would solve the problem. I don't think it would. We need to value the potential of professional leadership within localities, partly because of the long-term commitment that is made. GPs are in these communities for longer than almost everybody else. When a Holyrood magazine reporter interviewed 3 Govan GPs, I was able to tell her that there were 60 years of experience in the room, and there was just 3 GPs. That's an enormous amount of cumulative knowledge and experience of a local population, which needs to be valued and supported. The amount of money that would be needed to develop a local health system around practice would only involve a relatively small component that would be channeled through the practice. Much more important than that is the development of a leadership role so that the practice engages more effectively with what is round about it. This isn't a recipe that can be rolled out everywhere immediately. As Hugh McDermott said, we don't want tradition, we want precedents, and to learn from precedents. I think that's the only way forward, is to invest significantly in spearhead local health systems from which we can learn and share that learning.
Anyone else? Yes, John.
Hi there, thanks. I agree with what Graham's saying there completely. The other thing that we haven't really touched on is in terms of training. We've talked a little bit about professional culture, raising the aspirations of new doctors to work in deprived areas, and to see the need for the NHS to be at its best where it's needed most. NHS Education Scotland have been involved in funding a scheme with health inequality fellows for the last 4 or 5 years. There's the equivalent of 2 whole-time health inequality fellows who have been placed in deprived practices. One half-time post is actually with myself at the homeless practice in Edinburgh. It's been a hugely successful project, although very small scale. It could very easily be scaled up. It gives people the opportunity when they finish their GP training to extend that training and to see working with deprived communities, with patients with multiple complex needs, as something of a subspecialty for GPs, which raises the professional culture in terms of working in deprived practices. It's also a huge resource for the practices they work in terms of clinical work they're able to engage with, research that they do, and also to a little bit freeing up GPs to get involved in some of the other areas that we've been talked about, such as issues about partnership working with social care, or being able to get engaged in the integration agenda. So training, particularly in the postgraduate area, I think is something that could be very easily scaled up and would have multiple effects that would be very, very productive for patients and practices.
Is there any other questions? Aileen?
Thanks, Convener. I mean, the only question I was going to ask was just around one of the measures that's been set out in the Deep End GP's report, and that's around the new link worker programme, and obviously how the panel see that in terms of the role and contribution that the new link workers attached to the Deep End GP practices will make to helping us reduce health inequalities. I know that's a programme that's been supported by the Scottish Government and also with the Alliance and SAMH, and actually helping the staff in primary care become better at identifying the local support groups and organisations that are available in their own communities, and being able to kind of better match that to the specific needs of the patients.
Will we get any experience of that, Graham?
I'm on the executive group of that project. I think it's a very important and timely project, which builds on quite a lot of previous work, but now it has actually the full-time link worker posts in 7 Deep End practices. I know that the 7 individuals who've been appointed are of a very high calibre in terms of what is actually required to operate in this role. It's too early to know how it's going to work. We know from previous projects like the Links project and the Bridge project that link working isn't something that you can press a switch and it happens. What you're talking about is a multiplicity of links with different organisations, pathways that people would follow. Some of them will work, some of them won't work. Some patients will be up for it, others won't be. I think if the project is allowed to develop slowly by trial and error, developing a system that's customised to each practice, I think it's very hopeful. I think if it's rolled out as a blueprint where people try and tick boxes, it won't work. It's an extremely important part of the jigsaw, because it potentially links practices to everything that's going on round about them. And one of the unintended consequences of the QOF was it made practices very introspective and not looking so much round about them. Whether that problem is to be solved by a new person whose job is a link worker, I don't know, but it's certainly the way forward at present. It's only one part of the jigsaw, linking the practice to community resources in the third sector for health and social well-being. We actually need something very similar to improve the links with other services. You know, mental health, addiction, health visiting. Attached workers might be the problem, but if you can't have attached workers, you need some kind of link with secondary care, for example. All of those links need to be identified and worked on. At the end of the day, a local system is simply the sum of the relationships that are contained within it. And the quality of those relationships, or the social capital, is what the system comprises of. And we're currently very good at managing the financial resource within a system, but not the human resource. A local health system depends on multiple relationships, and if they're not the most productive relationships at present, they require work and effort to make them work. It won't happen overnight. But that has to be the direction of travel. You know, Spike Milligan, the machine that does the work of 2 men takes 1 man to work it. That's only going to happen if that man's got very good relationships with everybody who could put their shoulder to the wheel.
Anyone else on that? Yes, John.
Yeah, I think certainly the DIG group in Lothian see that as a really positive move to develop this link worker project. In the southeast of Edinburgh, in Craigmillar, there's a project with Community Renewals, an organisation which you might be familiar, looking at case management, which is very much about working with patients with multiple and complex needs who aren't engaging with any services, and working with them one-to-one over a period of time, and actually linking them in and supporting them through making use of services, which seems to be showing really positive results, which is something that I think the link worker might well move into, because it's not just about signposting and information. It's about enabling people to engage with resources that are in the community, because we know there are many projects which offer all sorts of things, but local people don't engage with them. And I think that was one of the things that came out of Keepwell, how you actually effectively enable people to engage with the resource that's there. And so something like a link worker, I think, is really positive. And I think GPs would be very, very supportive of that.
Lorna.
The link worker programme is being tried out in Glasgow, so we're connected into it with the CHP services as well. And one of the things that we're keen to see from the evaluation is the impact of the link worker role and how that works, but also just the impact of additional resource, because the pilot is additional resource into practices. It's being used for a link worker role, but we'll need to see from the evaluation, is it the additional resource that makes the difference? And if so, what's the best thing that you could do with it? Or is it specifically about the role of the link worker? And I think that will help us with some of the questions we've been grappling with here around both the amount of additional money you might want to put in, but also about what you would do with that money if you had it.
Anyone else? Graham, you want to come back?
I think this question of learning from it is really important, because many of the issues that we've identified, we might imagine solutions to them, but we can't be sure that we've got the perfect solution. I think the important thing is to determine a direction of travel and a commitment not only to learn from it, but also to share that learning. And we lack infrastructure at present to do that. Practices, as Andrew was saying, don't have the infrastructure or means to meet, to share and compare experience and views. The Deep End project shows what can come out if you do provide that infrastructure. You know, if you use routine data and statistical ranges to determine outliers and try and manage that, that's one approach. But what you actually want are to shift behaviour in the mainstream by influencing professional norms of what people feels acceptable and what they aspire to. And that can only really be done in the absence of routine data on the basis of shared views and experience. And I think that committing services not only to develop new ways of doing things, but also committing to learning and sharing the learning, I think that's a really important part of the prescription for the future.
Thanks for that. Is there any other members who wish to ask any other questions? From the witnesses' point of view, is there any issues that you would wish to put on the record that haven't been brought out by the discussion? See, Lorna's got her hand up.
Just one issue, and it was in part to bring the patient voice into this. We did some work last year engaging with groups with protected characteristics, and a lot of our conversation here has been about deprivation, but this was looking at groups with disability, different sexual orientation, different races, religions, and so on. One of the very strong messages from that engagement was the extent to which people valued primary care, and they valued primary care because of the relationship that they could build up and the knowledge of their personal circumstances. So, for example, if somebody was disabled and had a personal assistant or particular access requirements, the practice knew what those were, understood who might come with them and how all of that worked. Whenever they had to go to access another service, particularly in hospital, they had to explain themselves over again, go through the fear of not knowing whether they would have their needs accommodated, whether they would be called for an appointment that they would miss, all of that fear and uncertainty. And I think that supports a lot of what we've been saying in the context of deprivation about the value of primary care and the value of relationships, but in a slightly different sense with some of the perhaps smaller groups or marginalised groups that we've not talked about so much, around the real value of that relationship, the knowledge of the individual and the way in which services can respond to their needs.
A timely reminder, I think the evidence that we had last week in and around gatekeepers and that transition, and indeed some of the work that we've explored in the transition from children's services to adult services are very similar issues there about that issue of trust, continuity of care, and going from one system to another. So we appreciate you just underscoring that there. Graham?
If we're on to the last points, our paper ends up with this conclusion, which I think is a really important one. I mean, universal coverage is very important. It gives everyone access on an equal basis, as Pauline described, but it doesn't provide for practitioners to respond proportionately to need. This is the equity issue that Pauline described. Yet the assumption often is that because we have universal coverage, that we have solved the problem. I mean, this is one of the reasons why Americans find it so difficult to imagine health inequalities in the NHS, because they think that universal coverage has solved the problem. It has solved one problem, but it hasn't solved the problem of responding proportionally to need. And I think that's a principle that the committee might adopt as something that the health service could be called to account on in its delivery.
Andrew?
Just in final points, I think we've made the point that there is a need to find a way of greater investment in primary care and to build the services around the primary care team in the local hub. I just want to make one final point about the need to stabilise the workforce. I think there are signs that we are on the cusp of a recruitment and retention crisis, and something needs to be done very soon to promote general practice as a career choice, and that could also emphasise the benefits of working in deprived areas and indeed rural areas. We need to do something about retaining and returner schemes for doctors leaving, so they do not leave the profession forever, because that is a major amount of resource in training them if they're lost forever to the service. And we need to do something to encourage GPs towards the end of their career to stay on for a few years longer. And finally, if any of the Health Committee would like to take up the option of visiting a general practice, I would be more than delighted to arrange that so you can see what a general practice is like today.
Yes, okay.
Just to say that we do have some of the tools to consider equity in the system and to think better about proportionate, universal services. But we need more push in the system to enable us to do that. We need to be asked to be, to provide equity analysis. At the moment, it's on the margins. It's, that kind of research is still fairly marginal. So we need something system-wide to be able to bring some of that information to the fore and to build it into the tools for planning.
Yes, John?
Yeah, and I'd like to extend the invitation to my practice as well, to any members of the committee. We do operate as a hub, as a one-stop shop, co-located with social work and housing. We have an extended primary care team with attached workers, CPN, addictions workers. It's the kind of model that we've been talking about today. It could be a basis for in terms of integrated working, and it might be useful for the committee to come along and see how it works, strengths and weaknesses, and some of the learning that we've experienced over the years in developing our service.
An example of the thing that Pauline's talking about would be the issue of access to specialists. You know, the use of hospitals for emergencies pretty much reflects need, because there's nothing to stop people being admitted. But the use of non-emergency hospital services, either outpatients or cold admissions, doesn't have the same slope. It's much nearer a flat distribution. And there are lots of reasons why that may be the case, mainly because there are so many social processes to get into hospital to see a specialist, and it's partly to do with patients, how they present, how that initial encounter ends. I think once you get into the system, equity is pretty good. But as Ian Gray in the audit committee looking at cardiological services commented, there are problems in encouraging people to use the services to which they're entitled. And much, you know, looking at the social patterning of access to specialists would be a very good example in which to start the sort of work that Pauline's describing.
None of our other witnesses? Go on, Bob.
Convener, I was actually inspired by yourself, Convener. The only reason I'm doing a final comment, because you mentioned gatekeepers to the system for access, and Lorna Kelly spoke about marginalised groups. This committee has done really well on a cross-party basis to have a Scottish way in terms of access to healthcare. So I just hope we can get the sense from some of the witnesses here that there's been no appetite from the witnesses here to support Lord Warner's comments that the NHS should be a subscription-based service, because I can only imagine that the additional barriers to access that might create, and it would seem weird not to, given the topicality of that just now, not to put some of that on the record, given that we are talking about access to private healthcare here at committee this morning.
I think it would be a very retrograde step to go down that line.
Speak for you all. You sure? Is there anyone else? Can I thank you all for giving your valuable time this morning and the evidence you provided, and we look forward to continuing with this theme from the committee, and with your help make incremental differences in the road maybe. Thank you very much for all your time this morning. Thank you. Thanks, Graham.
Think how much I'd have spoken if I wasn't sitting next to you.
Pardon?
Think how much I'd have spoken if I wasn't sitting next to you.
I know.
I need to announce we're going into private session.
We're now going into private session.